future topics or future speakers. Today I have the pleasure of introducing Dr. Mike Kitchell. Dr. Kitchell is a neurologist. He's board certified by the American Board of Neurology and Psychiatry. He's also certified by the American Society of Neurorehabilitation, but more germane to today's topic. He's also an expert on healthcare payment reform and in fact has even testified before the Senate Finance Committee on such matters. He also, to the best of my recollection, is the only recipient of both the Mary Greeley Excellence and Innovation Award and actually the McFarland Clinic Founders Trusted Choice Founders Award. So please join me in welcoming Dr. Mike Kitchell.
Thanks. So can you hear me through the microphone, I presume? So today I'm going to be doing a little bit of alphabet soup, but this is going to be concentrated on payment reform for physicians and other providers. And obviously it's going to affect everybody in the healthcare profession. Now, I'm a member of the American Academy of Neurology Payment Alternatives team, and my group of neurologists advises other neurologists around the country about some of the newer payment models that are coming out. And one of the things that we're working on is called an alternative payment model, APM. And McFarland Clinic has already been successful in these alternative payment models. These are ways of getting paid either for quality, for meaningful use of the Epic medical record, or for other pay for performance. And McFarland Clinic over the last 10 years has earned over $12 million by these alternative payment models. We've gotten paid about half of that for the meaningful use using the electronic medical record. We've received money from Wellmark for our quality, and we've received money from Medicare for quality. So that's an alternative way of getting paid. Instead of just running faster on the treadmill, doing more RVU units, we do things to result in better care for our patients. So that's what this talk is all about, is how the payment system is actually changing to reflect a new way of paying physicians and other providers. So just some of the things that I'm going to be talking about today are MACRA, MIPS, APMs, and what the impact is for physicians and other providers of all these new things coming down the road. So I think most of you have heard me in other talks talking about why these changes are coming, why we cannot continue on this unsustainable path of expensive and relatively low quality of care. You might have seen the news today where the third leading cause of death in the United States, is medical errors. So this is putting a lot of focus on why we need to do a better job. The lack of price transparency is also hindering the payment system, because obviously patients really don't know how much things cost. And if consumers knew that there were some pretty big differences in price, they might change their behavior too. So it's really the end of an era, the old-fashioned way of getting paid just to make more widgets or do more procedures. In the future, payment will be based on results, it'll be based on outcomes, it'll be based on quality, and it will be based on having providers be cost conscious. And this is a graph of how spending is going up. The green represents Medicare, the gold is Medicaid. So the public payments are taking right now about 6%, 5 to 6% of the gross domestic product. And by the end of this graph in 2040, they'll be taking up about 7 or 8% of the entire gross domestic product. If you add the private spending, which is 55% of all the dollars spent in healthcare, and you add the public spending, Medicare, Medicaid, et cetera, you're coming up with about 17 to 18% of every dollar spent in this country is spent on health care. So if you don't know what MACRA is, it's called Medicare Access and CHIP, that's Children's Health Plan, Reauthorization Act of 2015. And I presume most of you think that what's happening in Congress is really pretty dysfunctional. It seems like the Republicans and the Democrats can never agree on anything in Washington. So when you think about over the past couple of years, what did the Republicans and the Democrats agree upon? This is a really good example where there was almost a unanimous vote. If you think Congress and Washington is dysfunctional, we'll look at the results of this. Over 90% of the House voted for this MACRA bill, and 92% of the Senate voted for this bill. So the impact of MACRA has nothing to do with Obamacare or the Affordable Care Act. And if people think that whichever political party comes in, there's going to be some change to this MACRA, I think you're going to be mistaken. So again, this is a bipartisan, overwhelming decision to change the payment system for providers. So if you recall some of my other talks here, physicians were always worried about the sustainable growth rate formula. We had cuts of 21 to 24% threatened the last few years. And so this MACRA Act actually took over and eliminated that penalty that was always hanging over physicians' heads. It was temporarily rescinded at the last minute. And so it's going to establish new updates, not very high increases in payment, but a little increase in payment for a number of years. And then it's going to streamline the existing quality programs into what's called MIPS, Merit-Based Incentive Payment System. So I'm going to talk about two main things today, MIPS and APMs. You can think of MIPS as fee-for-service, kind of traditional RVU care, and that's going to have a bonus or a penalty that's pay for performance. That's MIPS. Alternative payment models is the other pathway that physicians are going to have the option to choose from. That alternative payment model is something we'll talk a little bit more about as I go along. And these are who MACRA affects. It's going to affect the optometrists, the podiatrists, the nurse anesthetists, APPs, and of course physicians. The payment reform, you've heard me say this many times too, instead of doing more procedures, more activities, it's going to be based more upon the value of that, whatever the action of the provider was, to the results for the patient. So it's going to switch from more volume to more value. As you probably know, neurologists get paid more to do sleep studies, and we get paid more to do EMGs. Well, in the future, we may find it more valuable for neurologists to actually talk to patients and treat patients than just simply do more procedures. So this is where the payment system is going to be making some big changes. So again, as I said, it eliminated the SGR. That was a potential 21 to 24% cut in physician payments by Medicare every year. And there's still a few things to be worked out for MACRA, and that's where advocacy and some rulemaking is still taking place as we go along. So the current quality programs in Medicare, McFarland Clinic has participated with the PQRS from day one. Even last year, only 60% of America's physicians participated in the PQRS program. And those physicians who don't participate in PQRS in 2017 are going to find a 6% penalty from Medicare if they keep their heads firmly in sand. So again, this quality reporting system will be merging into other quality programs like the value-based payment modifier. The value-based payment modifier has been going on for a few years, and large groups like McFarland Clinic were competing with this value-based payment modifier, which actually has both quality and cost components. McFarland Clinic did very well the last few years with this value-based payment modifier, but since 80% of the physicians didn't get a penalty or a reward, we were one of those who didn't have a reward, even though we were a high performer in the value-based payment modifier. If the physician group like ours didn't participate, they would be susceptible to a 4% penalty. So we had to report quality data to be successful in the value-based payment modifier. As I said, we didn't reach that bonus because they set the bonus levels really high, and of course there were the penalty levels too. Now the third part of the CMS quality program was meaningful use, and as I said, McFarland Clinic has been very successful in getting about $6 million total from the meaningful use program. And so we're near the end of the bonuses, the payments for that meaningful use program. And physicians who don't participate with an electronic health record and the meaningful use program, they will be seeing a 3% penalty. It's a 2% penalty this year, be a 3% penalty next year. So if you add up all those penalties, it comes to about 10% for some physicians who, like I say, if they want to have their heads firmly in the sand, they might just want to drop out of Medicare, because a 10% penalty in Medicare is since Medicare doesn't pay that well, 10% less than that is probably going to mean the end of Medicare participation for a lot of physicians. Now, as I was saying, these quality programs, which are on the left, they are going to be merged into what's called the merit-based incentive payment program. That's the pay for performance. So this will be fee for service, and then physicians who excel in these three, plus the new one is the fourth category. Physicians who do well in these four categories will be getting a bonus, and physicians who do poorly will be getting a penalty, and that penalty is going to ramp up pretty quickly over the next few years. Or, like I say, the alternative for physicians is MIPS or this alternative payment model. And there won't be a third alternative. Physicians will be forced to choose one or the other. The alternative payment model, just to make it simple right now, that includes an accountable care organization, which McFarland Clinic has been doing for a while. But there's some rules that I'll talk about a little bit more later. So as I said, these three programs, meaningful use, the physician quality reporting system, and value-based payment modifier, they're going to go into the MIPS program. And there's a fourth part of that quality payment or MIPS program, that pay for performance program. It's called clinical practice improvement activities. And it's important to pay attention to this because we're almost halfway through 2016. The payments for 2019, which is the first year that these payments will be based upon, that's the first year they'll pay that, they're actually going to be measuring in 2017. So if physicians do poorly in 2017, that's going to result in their penalties in 2019. So many physicians who have their heads in the sand are going to have a pretty rude awakening in a couple of years. So as I said, the MIPS categories are these four: quality measures, resource use. Resource use came from the value-based payment modifier because, as I said, McFarland Clinic, we did very well with quality. We also did very well with resource use. Resource use is cost, how much was spent on the patients. We know from McFarland Clinic's quality resource use reports that we are very low in cost. And part of the reason we're low in cost is that we actually give better care to our patients. One example that I've given here before, we continue to excel at McFarland Clinic in diabetic care. Our diabetic patients are basically costing Medicare about half of what the average diabetic patient costs, and our diabetic patients are admitted to the hospital less than 1/2 the national average. So our diabetic patients don't go into the hospital because they had a stroke. They don't go into the hospital because they had a heart attack. They don't go into the hospital because they had an amputation. Our diabetic patients, by and large, are doing quite a bit better than the national average. So we also do better with our COPD patients. We also do better with our congestive heart failure patients. So again, we're not only higher quality, that higher quality results in lower costs. And isn't that what our diabetic patients want? Isn't that what our COPD patients want? Isn't that what our CHF patients want? They'd rather not be in the hospital. So again, these 4 categories are going to be important in the new payment system. This 4th category, called clinical practice improvement activities, is yet to be fleshed out very much. This is a graph of what the weight of those is. 30% of the payment is going to depend upon these quality measurements. 30% of the payment is going to depend upon the cost, the resource use. They've decided that the first year, since most physicians are not cost conscious, that they're actually going to have 50% of these 2 payments are going to be quality, and only 10% for the first year will be cost or resource use. But it will ramp up in a few years, so it'll be 30% cost, 30% quality, 25% the use of electronic health records meaningfully used, and then 15% will be this clinical practice improvement activities. So as I said, these MIPS, which are pay for performance, on top of the fee-for-service payments that physicians already get right now, it's going to be very similar to what has already been going on. And the quality measures that they're going to use are going to be coming from these 5 categories: clinical care, safety, how many complications did the patients have, care coordination. Incidentally, we are one of the top care coordination organizations in Iowa, according to our Wellmark quality data as well. This quality measurement will also depend a lot upon the patient experience. So that's why McFarland Clinic has been putting a lot of focus on making sure we have an improvement in our patient experience scores. And then population health and prevention. This is truly trying to keep people healthy, trying to keep them out of the hospital, just like I gave you the example of the diabetic patients. If we can keep these people healthy, if we can keep the sicker patients from bouncing back into the hospital, that's good for everybody. Now, the quality measures, as I said, are going to be more toward outcomes. And you may say, okay, well, what's a good outcome? Well, a good outcome might be a lack of complication from surgery. A good outcome might be a lower percentage of readmissions. The readmission rate at Mary Greeley is about 13%. That's quite a bit better than the national average. But if we could make that readmission rate, 30-day readmission rate, 9%, that would be even better. The patient experience, we do know that at McFarland Clinic we have pretty good scores. Mary Greeley has very good scores. That's the hospital scores, though, as opposed to physician scores. And then care coordination, like I say, I think those of us who have been part of McFarland Clinic for a long time, that's one of the things we take a lot of pride in, is coordinating the care of our patients. And then resource use, how much are we spending on these patients? If we can keep them out of the hospital, that's going to save a lot of money because they didn't have those expensive hospital stays. So resource use, as I said, they're going to find different ways to look at resource use or the cost of care. Some of it's going to be care episode groups. For example, how much does a heart attack cost? That episode of care around that heart attack, an episode of care around another illness. Patient condition groups. This is why at McFarland Clinic we've been trying to emphasize proper coding. We found that at McFarland Clinic we weren't coding as well as we should have for the diagnosis of the patients. For example, a lot of our diabetic patients, we weren't even coding the fact that they had diabetic retinopathy or they had diabetic neuropathy. Those codes for diagnosis indicate that that patient is sicker. And we do know that when people are sicker, they cost more money. So again, those diagnosis codes are important to get those accurate so that we get credit for taking care of those sicker patients. So resource use will depend upon what's called a risk adjustment for the sicker patients. And then again, for the patient relationship categories, for example, at McFarland Clinic, we want every patient to have a primary care provider. And that's how most of this attribution of cost is concerned. So that means if our primary care physician or APP sends the patient to an inefficient provider, let's say someplace other than at McFarland Clinic, if that provider, that specialist that they send those patients to is inefficient, does too many tests, too many procedures, that will mean the resource use is higher, and those people are attributed to the primary care provider. That is, so if a McFarland Clinic primary care provider sends a patient to an expensive specialist, that's going to result in lower scores. So meaningful use will be pretty similar. A lot of physicians have had some pushback against meaningful use, but I think at McFarland Clinic we've had overall a pretty good acceptance, and I think we've done quite well with most of the physicians with the results of meaningful use. So as I said, the new category, which is about 15% of that bonus for the MIPS, for the pay for performance part of this choice that physicians will face in 2019, but like I say, it's going to start in 2017 because they're going to have to measure before they actually do any payments in 2019. But some of the alternatives for these performance categories for the clinical practice improvement includes expanded patient access. We all know what a difference it makes if patients have good access as opposed to poor access to their physicians. Population health management. McFarland Clinic has a whole department now on population health management. We are trying to identify the patients who need the most care and get them in. Don't let them get sick and just pop into the emergency department and get admitted and have a costly hospital stay. Because again, it's better care. If we identify these people, treat them in the office, we can avoid not only expensive complications, but unpleasant complications for those patients. So care coordination, beneficiary engagement. What we're trying to do with our patient experience committee at McFarland Clinic is not only improve the scores of their satisfaction, but also get patients engaged. If we have our diabetics engaged in better care, if we have our asthmatics engaged in better care, they're going to need less care. They're going to be healthier and they'll stay out of the hospital and reduce costs. Again, it's better for everybody. So again, patient safety and practice assessment. We've got to make sure that our patients don't fall through the cracks. Mary Greeley has been awarded a category that's the highest in the state by the Leapfrog group. This is a group that measures quality and patient safety. And if you haven't heard that Mary Greeley is the top performer in the state, you're hearing it now. The quality and patient safety here at Mary Greeley is excellent. And then the last portion of MIPS, even though you may choose MIPS rather than the alternative payment model, if McFarland Clinic, for example, chose the MIPS pathway, we would still get some credit by being in an alternative payment model or an accountable care organization. So at as I told you before, McFarland Clinic has been participating with this value-based payment modifier for about 4 years, and we didn't reach the top level that gave us a bonus. But in this MIPS program, it's not going to be an all or nothing thing. It's going to be graded on a scale of 0 to 100. And of course, some physicians are going to fall below and they're going to get a penalty from this MIPS program. And as I said, this is going to be starting in 2017. Medicare is going to give feedback to physicians so that they know in advance how they're doing. It's still a little old data. This is where they're going to try to go from a 2-year gap, because we would get the results of our 2014 data about 1.5 years later, almost 2 years later. So Medicare's trying to get that data out more quickly to physicians so we know how we're doing. This is one of the advantages of us at McFarland Clinic working with Wellmark. Wellmark gives us data that's maybe 6 months old, somewhere around that, maybe 7 months old. So Medicare's got a little more trouble with getting the data out to us, but we need that data to manage care a little better. So data registries are basically a way to make sure patients with diabetes or patients with another medical condition are getting all the proper things that they need. So that's part of the meaningful use program too. So again, MIPS is going to depend upon using data, using feedback wisely to do a better job of taking care of our patients. So this is just a graph. You can see the yellow line is the potential bonuses going from 0% up to about 9%. And then the green line is the current 2015. Like I say, there's a 4% penalty if you add all of them together. But in 2016, it's going to be about 6%. 2017, it's going to be about 9% penalty. In 2018, physicians, like I say, have their head firmly planted in sand, they will get a 10% penalty from Medicare. So as the MACRA phases into 2019, the penalties actually reduce a little bit for a while, but then you can see that green line is going down, and it will again go down to a 9% penalty. So like I say, those are the physicians who just don't want to participate. If we were to gauge where McFarland Clinic stands right now, I would say we would probably be in the range of a 5 or 6% bonus, and depending upon what the clinical practice improvement activities, we might go quite a bit higher. So McFarland Clinic is going to be faced with a decision in the future, which of these two pathways do we want to do? So let's talk about this other pathway now. I've been talking about MIPS, which is that pay for performance on top of the usual RVUs and fee for service type of work. So this is an alternative way of getting paid. Like I say, McFarland Clinic has already been doing these quality reporting initiatives. We've already been doing the meaningful use, and that's what we call alternative payment models. And so the nice thing about the alternative payment models is they've got a nice bonus. So if you just go into this alternative payment model in 2019, the physician group will get a 5% bonus on everything that they do. The problem, though, is there's a little bit of a few rules that we have to abide by, and I'll talk about that now. We already have electronic medical record technology. We already are looking at our quality measurements. But one thing we don't do at McFarland Clinic right now for Medicare is we don't take risk. We take risk at McFarland Clinic on the Accountable Care Organization contract with Wellmark. Wellmark will pay us some of the shared savings if our physicians bend that cost curve down for Wellmark. That's called shared savings. We get some of the savings from giving patients better care. And in Wellmark, this is the first year, 2016 is the first year that we now have what we call downside risk. In other words, if we don't bend that cost curve down for Wellmark, if we don't stay below the budgeted amount, then McFarland Clinic physicians will be paying Wellmark back. That's what we call downside risk. And so McFarland Clinic has been participating in accountable care organization contracts with Medicare last year and this year too, but we do not have, I said we do not have downside risk. So we might get some Medicare shared savings if we do well with our ACO, but we are not liable to pay Medicare back with the current contracts. But what this alternative payment model means is in 2019, we already have to have a certain amount of our patients under those downside risk contracts. So that means we take risk on the cost of the care of our patients. And as it says here, there will be more criteria that will be coming out by Center for Medicare Services. So our accountable care organization is only one type of alternative payment model. As I said, as part of the American Academy of Neurology Payment Alternatives team, we've actually been developing an alternative payment model for neurologists in taking care of headache patients and in taking care of epilepsy patients, and we're going to be doing more alternative payment models too. So what it is we're not just getting paid fee for service, we're getting paid to give the patients better care, show better results. And so again, the criteria for the alternative payment model is just simply, you got to show that you're giving better care, better results for the patients at lower cost. So that's what an alternative payment model is all about. This is a graph of how the future is going to come up. The conversion factor update means that the base rate for the fee for service is just going to go up about 0.5% for 5 years from 2015 to 2019. And then the base payments are going to stay the same until 2026. So if you did nothing else, you would hardly be, you wouldn't keep up with inflation. For the costs of physician practice going up at 2 to 3% per year, Medicare has never been keeping up with medical inflation. So again, on the graph where it says MIPS adjustment factors, again, that's what I was saying. Those penalties could be as much as 10% before this MACRA takes place. Then when MACRA starts, the penalty will actually lessen to 4%, but then every year it goes down to 9% penalty. So again, the physicians who don't participate, if they just have their heads in the sand, they're going to have a 9% penalty. And as I said, the alternative payment model bonus, if McFarland Clinic chooses to take that alternative payment model route with an accountable care organization model with downside risk, then we actually get a bonus of 5%. And you say, well, we could get a 9% bonus with MIPS rather than a 5% with the alternative payment model or ACO. The problem, though, is the ACO, you might lose or gain. You might have shared savings. You might have losses. So again, you have to perform if you're going to be an alternative payment model. Just like you have to perform if you want to get some increased bonus from the MIPS. Now, this last column, which is Medicare revenue from the alternative payment model, they're phasing this in. If we only have 25% of our total patients in an alternative payment model, that is an ACO, then we're eligible. But that eligibility goes up to 50% of our patients have to be in an accountable care organization by 2021, and then it goes up to 75%. So you really have to have a lot of your patients at risk for those losses or gains in the future. So again, as I said, in the future there will be some tiny increases in base pay, but the future is really going to be based upon succeeding or failing with this value proposition. So people ask, what else did MACRA do? As you may know, they put all kinds of rules on physicians for meaningful use, but they made no rules for the electronic health record companies to be interoperable. So we don't have interoperability between Epic and other computer systems at this time. So finally, Congress is going to force these companies to be interoperable. And then there's going to be some funding, like I say, for developing more quality measures for these alternative payment models. And then CHIP, which is the Children's Health Plan, which is really critical here in Iowa. A lot of kids in Iowa are covered by CHIP. Dr. Carlisle knows about that. He helped to get CHIP going here in Iowa many years ago, but that is reauthorized. But again, it has a time frame that's limited. And then you've heard me give some talks about geographic practice cost indexes and how Iowa gets paid much less than most other states. We actually kept our temporary floor that raised our payments about 2%, but that's only through the end of 2017. So what's the bottom line for MACRA? Again, it's a huge impact because it's going to change how physicians are being paid. If you think that only Medicare is going to do this, you're wrong. Wellmark is well on its way toward really bolstering up this accountable care organization or alternative payment model type of contract. And so the biggest thing, though, that physicians don't have to look forward to is this 20 to 25% cut for the SGR every year. MACRA, as I said, was something that was bipartisan. It's not like Obamacare, where there may be some changes in the future. There will be significant practice implications for all providers. Everybody's going to have to be more cost conscious. Everybody's going to have to be more quality conscious. And then there's a steep learning curve to prepare for this. But I think at McFarland Clinic, we've been well on our way toward getting our physicians to be more quality conscious. Probably have to be a little more cost conscious in the future. We'll need to develop more metrics. If you can't measure quality, how do you know you're improving it? So we've got to have some more measures of quality. But like I say, you can measure quality by admissions or lack of complications. Like I say, our diabetic patients are a good example of how those measurements actually show that we're giving good care. So again, there are going to be more reports on performance. At McFarland Clinic, we actually have a data analyst now who's giving some usable, actionable data to our primary care physicians. And I think that's going to be very helpful as we go along to improve our performance on these things that we need to pay more attention to. And then, as I said, this lag of 2 years by Medicare for the data, it's going to come down to about a year in the future. And then we still need some people advocating in Washington for the right rules and not the bad rules. So again, overall, as we look at our future, since we at McFarland Clinic have done really well and never really gotten paid for the value of our care, we're finally getting that recognition and that payment to pay for our improved value for our patients. So what do we have to do? We have to learn more about quality measurements, which actions can improve our performance on those quality measurements, and resource use or cost measurements. We need to participate in data analysis and feedback. Like I say, that's why we have a data analyst, is to give our physicians more of that feedback. It's not just physicians, obviously. It's everybody in our organization, our APPs, our staff. We've got to have everybody working toward better care. If we put all this work on our physicians or our APPs back, they're going to break down. We've got to have our staff help us with improving our care processes. And obviously, the electronic health record and other data and analytics will help to improve our performance and the outcomes for our patients. So I'd encourage everybody here to learn more about these measures and patient experience. We're all in this together, whether it's the receptionist that's the first person that our patient sees, or it's the bill that comes in the mail. It's part of the whole patient experience. And getting our patients engaged is going to be very important too, because as I said, with those patients who have chronic diseases, whether it's diabetes, COPD, asthma, congestive heart failure, the more we can get those patients working with us as providers, the better off they'll be. We'll keep them healthier, we'll keep them out of the hospital, we'll keep the costs down. So, are there questions? Hope you have some questions. Dave, just wait till the microphone gets there.
Thanks, Mike. You know, I've been to 2 other talks about this, and at the conclusion of one, the statement was made that you really cannot be a solo doctor in the future in doing MACRA. And the 2 said, yeah, you can be a solo doctor, but you have to be aligned in some kind of greater group of multiple other solo doctors to make it work. And I just wondered your comments on that, and the fact that how we're probably pretty lucky to be in a group practice with
Right.
the way Medicare is going.
Yeah, actually, Center for Medicare Services looked at the data right now, and they have predicted that if things were just like they are right now, 81% of large groups, that's 100 physicians in a group, 81% of physicians in large groups would have a positive MIPS result, whereas only 19% of solo doctors would succeed in MIPS. So we're talking about solo or small practice physicians that are going to have a really, really hard time in the future, because I think it's pretty easy to say you need a critical mass of physicians to have a really robust electronic health record and to use those tools effectively. But you also need people. That's why we have a population health management department. That's why we have a data analyst. We've got to have feedback for our APPs and our physicians to do a better job, because a lot of physicians, we don't know if we're doing a good job or not. And that's where getting this data is important. So yeah, Dave is entirely correct. A lot of solo and small practice physicians are saying this is really going to hurt them. But the alternative, like I say, is to have them join either into some sort of virtual group or some other loose affiliation of practice management and data analytics and electronic health record. So I hope physicians who are solo and small practice are looking for that type of collaboration.
Yeah, Mike, it's interesting you brought up the Wellmark ACO contract. We found out a few months ago that Wellmark is apparently allowed to, in that contract, randomly assign patients to us that we've either never seen, have never even been in the clinic, or I saw 4 years ago for a cold. They're then allowed to assign a risk score of 0, which effectively stacks the deck against us showing any savings. Will Medicare be allowed to do the same thing?
I don't know that I can say whether Medicare will be allowed to do the same thing, but just knowing all the computer glitches in Medicare, I think we have the same concerns. We're just hoping that we're like any other physician group out there, whether it's Wellmark or Medicare, the accuracy of their data is not 100%. And we just hope their data accuracy, that attribution, just like you say, they're assigning a patient to you you've never seen. I'm sure Medicare has that same experience. We just hope that since we have so many patients, that at least the range of error is not too great. But you're right, this is not very accurate. I guess I can't comment whether that's intentional or not. I'm sure it happens, but yeah. Well, I don't want to lay all the blame on Wellmark, but they obviously want to put the responsibility for cost control squarely on the providers' backs. We are responsible for what expenditures are at the hospital, and those are greater than what we spend in our offices by quite a lot. And so you're correct. This is a wholesale transfer of responsibility for cost control from the insurance companies to the providers. And again, we just hope we can control as much of that spending as we possibly can. And that's where we have to learn how to do it better. Okay, well, if you do have some other questions, I'll be down here for a little bit. And I'm glad to hear any further discussion as we go along, too.